Okay, yeah, good afternoon. Okay, good afternoon, everybody. I welcome you to today's a class. So, we are going to continue our previous lecture on that phlebotomy. Then we'll round it up. Then other method of sample collection. We're going to choose other method of sample collection today. Then I know there'll be time. Then we'll do infection prevention and control, which will be our main topic for today. But I want us to round up the previous lecture. So we're going to start immediately. But before we proceed, I want to briefly talk about what we did last time concerning sample collection. I want to talk about the analytical error, which we mentioned that these are errors arising from method of sample collection. Because at the end of the day, when it still comes to other sample collection, such as sputum and urine, if you don't follow the right method to collect them, we could still end up with analytical errors. So, we say before sample collection, what are the things you do to ensure that you don't run into errors? Number one, ensure proper coordination of patients, verify time of specimen collection, verify usage of proper tubes. We mentioned tubes like different colors of tube cover, such as the red, the pink, and the rest of them. Purple, sorry. Then we mentioned verify that patient is prepared, such as if the patient is on drugs or is he fasting. Then during sample collection, the things you need to be aware, which includes wrong order of draw. Wrong order of draw, that's if you're taking the sample appropriately. Then extended tourniquet time, that the tourniquet which you tie to make the veins pop out, that you don't leave it for a very long time. Because if you leave it for a very long time, you might not collect blood in this natural form. You might collect either light or thick blood, maybe the one that is almost close to being clotted because of lesser blood supply to the vessel as a result of the application of tourniquet. Then we talk about hemolysis, which is a breakdown of red blood vessels arising from either disease, drugs, or happening naturally. So these are things that could result to analytical error. Then we talk about failure to invert the tubes. Some of the tubes, they have coagulants that when you take blood, you turn them upside down so that the blood can mix with the coagulant, with the anticoagulant, so that now when you want to preserve this blood now, they clot and become useless for the investigation for which you did them for. Then after sample collection, what are the things that could lead to analytical error? We mentioned improper storage of specimen, that if you don't store them appropriately, some specimen are supposed to be stored under certain condition, under certain temperature. So if you don't store them within that temperature, or if the temperature is high and they become heated, they might become useless. Then you talk about improper usage of serum separator tubes. That these are tubes that are used to collect blood sample, which separates blood cells from serum. So if you don't use it very, very, very well, you might not really get the good results, because when they are separated and in the course of trying to do the investigation, the blood mixes with the serum, it won't give you a very good result. Then we talk about clinical laboratory sessions. We mentioned the hematology unit, where mostly there is investigations done there, or laboratory tests done there are used to diagnose blood-related diseases. We talk about chemistry lab, which deals on mostly electrolytes and kidney function tests, liver function, chemical balance in the body, chemical and electrolyte imbalance in the body, even hormonal imbalance too, or hormonal balance. That's the lab whereby you take sample to. Then results coming out from there will indicate the amount of either the electrolytes or hormone or even sugar that is in the system. Then we mentioned the microbiology lab, which we said is divided into parasitology, whereby it treats certain kind of parasites. Then you talk about what's it called? The virology, dealing on viruses. Then bacteriology, where they study bacteria. Then you talk about the mycology, which deals on fungi and the rest of them. So investigations done there are meant to detect microorganisms, detect causes of infection or pathogens. Then we talked about the blood bank, whereby we discussed that you use the red cap bottle or even the EDCA, this is the purple cap bottle, to take blood sample for the blood bank, and importance of proper uh, labeling of blood collected at the blood bank, proper testing and labeling. We mentioned the very few things that could happen in the course of blood transfusion, which to an extent is outside the scope of our discussion. We had to bring it because we are strictly dealing on a blood bank. What happens in blood bank, where you collect sample for where they are prepared for possible transfusion into those requiring them. So we said that specimen for blood transfusion must the bottle must be labeled with the patient's full name and date of birth, patient hospital identification number. Then if it's outpatient, it must have a social security number. That's not for Nigeria anyways, but in Nigeria, I think they have a laboratory number for it. Then we have the date and time of collection of the sample, then the initial of the person collecting the sample. So now today we are going to be talking about it's a continuation of the lecture we had, a continuation of the lecture. So after the blood bank, we're going to be treating hemostasis and coagulation. Hemostasis, that is HEMO, then stasis, STASIS. So when you hear hemo, anytime you hear hemo, just like we mentioned hematology, which has to do with blood. So whenever you hear hemo, means we are talking about blood. Hematology, hematinics, when you hear drugs, when they say these drugs are hematinics, means that they're drug that boost blood cell production, such as folic acid, phospholates, and the rest of them. So whenever you hear hemo, it's talking about blood. Now, you're having hemostasis. What does it mean? What it means is hemostasis is a mechanism that leads to a cessation of bleeding from blood vessels. So when you do your phlebotomy now, whereby you puncture the vein either to draw blood or to administer the blood. Phlebotomy is strictly about most time you puncture vein. It's mostly to draw blood. It's not for drug administration. That one is a different ballgame altogether. So hemostasis is a mechanism by which the body or the body prepares itself to prevent bleeding from it. So it is actually the maintenance of circulating blood in the liquid form or liquid states and the retention of blood in the vascular system by preventing blood loss. I can define that again. The maintenance of circulating blood in liquid states or liquid form and the retention of blood in the vascular system. Vascular system means blood vessels, vein and artery, by preventing blood loss. So a more simpler definition is a mechanism that leads to cessation of bleeding from blood vessels. That is a process by which the blood stop coming out from the vessel. So that's hemostasis. So stasis means to stop. Hemo is blood. So stop blood. With this, it makes it easier for you to take this definition without having to even cram it. Then we have coagulation. What is coagulation? Coagulation is a process by which blood changes from liquid to a gel form or to form a clot. Then I think we mentioned the when I was talking about different types of lab, I mentioned there were sample bottles and anticoagulants. When you talk about coagulation, means the blood. When you see like an accident victim, or even when you bleed ordinarily and you leave that blood for some time, for something that looks like gel, it has thickened. So it's no longer the way it used to be. So When it happens, you say that clot has formed, and that is what you call coagulation of blood. So, what are the things that can prevent blood coagulation? There are certain drugs that you give to suppress clotting of blood. For example, there are some patients now that patients who are bedridden, or patients who are going to be maybe fracture patients or spinal cord injury patients who are going to be staying long on bed. Usually they place them on anticoagulants that suppresses this clotting so that they don't develop thrombosis, which is a formation of clot within the blood vessels, which is very dangerous, which can even lead to death. So you place those people on those drugs such as heparin, varosaban, or Xarelto. That's another name for the drug. So drugs like this now suppress, increase time. They have those who are constrained or limited to staying gift clothing. But for a combination, try to your system the time are you one is the mechanism that leads to cessation of bleeding. That's why when you take sample, you ask the person to put together, apply pressure. After some time, bleeding stops. Then the other one is blood forming clots or gel becoming gel-like, which is coagulation. These are very, very simple explanations. Then we talk about capillaries. What are capillaries? They are microscopic one-cell thick vessels that link arteries and veins that form a bridge between arteries and vein. So capillaries, they are in between the artery and the vein. Let me quickly chip in this. In the course of your practice, you want to give a patient injection. You insert the needle, and if it's IM injection or even a subcut, and you try to aspirate the needle, you try to draw it back, and blood comes out, please do not give, because most probably you've punctured the capillary. And once you give that drug, you injure that patient. You injure that patient. If it's on the buttocks, you might even injure the sciatic nerve. So very, very important. So I just wanted to chip it in while we still proceed with our lecture. So arteries are just the bridge between the vein and the in between the artery and the vein. Then you have the second one, which says that only vessels that permit exchange of carbon dioxide and oxygen between the blood and other tissues. So this happens within the capillaries. This is where gaseous exchange of carbon dioxide and oxygen happens, whereby the blood takes oxygen and releases carbon dioxide, which is excreted out of the system through the lungs, then through the respiratory tract. Then blood in the capillary bed is a mix of artery and venous blood. So these are simple terms. You know, we discussed earlier that vein carries blood to the heart, then artery brings them out. So that the blood in the capillary is a mix of both blood coming from either the vein or the artery. So That's by the way. Then briefly, we just talk about something that might not sound too important, but also very important because you might need it in the course of an examination or for your knowledge. We talk about needle, parts of a multi-sample needle. A multi-sample needle is not like the normal needle we all know. It's not like the normal needle we all know. Maybe when you come for your practical, I'll try to bring one so that you can look at it. So you have the bevel. The bevel is the opening before the pointed edge that pierces the body. You have the shaft, that's the length of the needle itself. You have the threaded hub, that's the top. They have the rubber sleeve over the needle, something that looks like butterfly. It depends on the needle. It has a blue one, it has a green one. So it has something that looks, that's what's called the rubber sleeve. Then sizes of needles now. How do you know sizes of needle? The smaller the number of the needle, the bigger it is. Which I just mentioned, a sample needle has a rubber that looks like butterfly. The multi-sample needle, now it says most butterfly needles, which are multi-sample needles, are usually 23 to 25 cc. I don't know if anybody has seen a 2 mil syringe, like for some of you who know about 2 mil syringe and that comes with a needle, and the 5 mil syringe that comes with a needle. Hello, I want us to do a kind of a discussion now before we proceed, but we'll soon move to the next topic for today. So I don't know, has anybody seen a 2 mil syringe with a needle and a 5 mil syringe with a needle?
The truth is, I don't really know which
It's
one is
small.
5 mil or
Okay,
2 mil,
okay.
but I know
So the
that
small,
each
the
time you
small
want to
needle.
take injection, they will just put it and they will tell you to turn your
Okay,
bum bum and they will, so I don't know which one is 2 mm
okay,
or 5. Mhm.
okay. Now, the smallest syringe, that small one, the smallest syringe that has a blue needle. There's a small syringe that has a blue needle that even used mostly in pediatrics. They have a bigger one of 10 mils, which is a bigger type of syringe. Now, what we're trying to say here, in essence, is that now, if presented a 2 mil syringe now, I don't know if you're all listening now, because this is more like a mini quiz now. I give you a 2 mil syringe now with its needle. I give a 5 mil syringe with its own corresponding needle. Now, which of them is 21 cc needle and which of them is 23 cc needle?
And I think 21 will be the 2 mil, while the 23 will be the 5 mil.
You felt it. You know, it's not. That's why I say the smaller the number, the bigger the needle. The 5 mil has the 21 cc needle, while the 2 mil has the 23 cc needle. So the smaller the needle, the higher the number. I don't know if you understand it now. Just like they teach in mathematics now, inverse proportion. As this one is going up, the other one is coming down. As the number is going from 2 mil, 5 mil up, the number is coming down. The number from 10 mil is 23, it could be 25, could be 21 cc for the 10 mil. Then for the 2 mil, is 23. I don't know if you understand it now.
Yes, sir.
The bigger the needle, the smaller the number. I don't know if it's understood now. The bigger the needle, the smaller the number.
I want to ask something. Does it mean, since you said the smaller the needle, the bigger the number? What does
Yes.
it mean? Is the quantity of the injection or something?
It has
Is
nothing.
that what they use to determine that?
No. It has nothing to do with injection. It's just calibration by
Oh,
manufacturers.
okay.
It's calibration. So when you go in there and you begin to ask, even in the pharmacy where they do all the wholesale, you say you want a 23 cc needle. You'll be expecting what's it called? Well, you'll be expecting the bigger needle, the smaller needle. But it's not. The 21cc is bigger than the 23cc. So the smaller the number, the bigger the needle. So that is it for syringes, so that we don't dwell on this. Then we move to syringes. We have different types of syringe. You have the 2 mil, the 5 mil, the 10 mil, depending on calibration. Some hospitals, some producers, you might still see other mils, maybe 6 or 8 mil in between. But mostly in Nigeria, what we use here is mostly 2 mil, 5 mil, 10 mil, 20 mils. Then anything above 20 mils will fall in within all the bladder syringe. You can see 50, 70 mil and the rest of them. So those ones are not used for injection. Then parts of a syringe, you have the barrel, you have the shaft, which is the length. You have that's the graduated barrel, is the where you have the numbers. You have the knob, which is the mouth where you plunge the needle. You have the plunger, which is that place you press to give injection. Then you have the shaft, which is the whole length of the syringe. So that's by the way, so that we don't dwell on that. When we meet, you will see a sample of a syringe and the parts. Just for you to have a fair idea of what some of those things look like, so that you don't black out completely when you see them. They have a collection on. We are now moving to other methods of sample collection. Collection of urine specimen. How do you collect urine specimen? Before you collect the bottle used for collection of urine specimen, urine as 2 specimen is a universal bottle. They call it a universal bottle. They are bigger and they have what's it called? They have a red cap. Some will have blue. Some will have a red cap, but they are bigger than the bottles used for collection of blood specimen. So they are a different kind of a bottle altogether. So that not when you start discussing tubes, you go and start bringing in a bottle for collection of or container for collection of stool or urine sample. So we're going to talk about different methods or different types of urine specimen collection. The number one is the random urine specimen collection. When you hear random means it can be taken, just like you say random blood sugar, it can be taken anytime, no restrictions. So you can take your take your urine sample any time of the day, morning, night, midnight, anytime at all. So samples collected, this it does not have any special method, just urinate inside the bottle, then present it for testing. So what do they usually use it for? Usually used for urinalysis, normal, specific gravity, to check alkalinity, acidity, and the rest of them, of the urine, color, and the rest of them. So you can collect that one randomly. They have a second type of specimen. We are now moving into those ones that require specific instructions. You have the midstream urine specimen collection. What is midstream? I think in your notes on your the paper you have there, it said it's a clean voided or a clean catch specimen. So what happens here is that if you're told in the hospital to collect a midstream urine specimen, number one, this urine specimen has to be taken in the morning. That very first urine you're going to pass in the morning. Maybe when you sleep, you're woken up in the morning around 5:30 or 6. That's the time you're going to take this urine specimen. How do you take the urine specimen? You bring your sample bottle. You go to your restroom. You void small. When you void small, you hold the urine. Then you now void a little inside the bottle. Maybe half of the bottle or just a little that you think will be enough for the investigation. Then you can now void out the rest. Then you cover your bottle, keep it, then take it to the lab in the morning. Or as you're going to work, or wherever you're going to, you can take it along with you, then submit it in the lab. What are these investigation needed for? They are mostly used in urine culture. They use it to test for presence of microorganisms in urine, because at that time of the day, the urine is concentrated. So the microbes also concentrated because they don't have much water to swim in. So you get a good catch of them at that period. So urine collected by midstream urine specimen are mostly used for urine culture or urine MCS, that's culture, microscopic culture and sensitivity. Then you have the 24 hours urine specimen, which is the third one we're treating today. Here, urine is collected over 24 hours. How do you do it? You're given a container. Maybe a particular time of the day, you can say 10 a.m. They will tell you to start, each time you urinate, put it inside that particular container. Just be urinating inside that container for the next 24 hours. When you go and come, you urinate. When you go and come, whenever you're pressed, you urinate inside there. Whenever you're pressed, you urinate inside there. Then when it's up to 24 hours, we take it to the hospital for examination. So here, the urine is collected over 24 hours period. Urine is usually chilled or refrigerated to prevent growth of microbes. So when you collect this urine, they take it to the hospital. We mentioned analytical errors, what could lead to errors. Now, it's already indicating one here that we mentioned the method of storage of a specimen. So if you don't store this urine the way it's supposed to be stored, it might alter the result. So that's why he said it's refrigerated. What does refrigeration do? Refrigeration does not kill microorganisms. I know some people think when you put your food in the fridge that microorganisms will die. No. What it does is to inhibit. It's heat that actually kills microorganisms. Cold reduces its growth or prevents its growth or keeps it static as where it is. So it is used to investigate or diagnose kidney diseases or high blood pressure or to detect kidney stone. So that is what samples like this are used for. When you collect them, they are used to diagnose either kidney diseases. All these are acute kidney injury, chronic kidney injury, kidney stone, that's a presence of crystals in your urine, then high blood pressure. Then testing urine now. When you're testing urine now, what are the things you test for? Number one, you test for pH. What is pH? pH is I think we did this in basic sciences, even in integrated science, where they teach you a degree of alkalinity or acidity of urine. So this falls under urinalysis. In urinalysis, you test for, what's it called now? In urinalysis, you test for pH, specific gravity, you look out for color and the rest of them. So when you're testing for urine, what are you looking for? Acidity or alkalinity? Depending on which one. If it's more alkaline, is indicative of something. If it's more acidic, it's also indicative of something. So that is it. Then what again do you test for? You test for glucose or ketones. Usually, it is used for testing for diabetes. When you test for sugar, what are you looking for? You are looking for, like in the hospital now, when people are admitted, they say you check their blood sugar is high. When their blood sugar is high, what do? You do a first urine specimen with a strip. When you dip that strip inside this, you compare it to the bottle, it will give you the number of ketones in that urine. So this is actually used to assess for diabetes. You can use it to know somebody who is a diabetic or a newly diagnosed diabetic. So here, acetones are seen in urine. That's where you say the patient has ketonuria. Or sometimes they tell you that somebody has diabetic ketoacidosis. How do you detect it? Because of the presence of ketone in urine. Sometimes you can have very high blood sugar without ketone appearing in urine, where you query just normal hyperglycemia or have a hyperglycemic hyposmolar state. There's no ketone, but in DKA you have ketone. So all these things now, it is the test, the urine test that is done that gives you an insight as to which one you're treating. Then you can test for blood. When you take a urine sample and you notice there's blood inside it, it's an indication of something. What it means, there's an injury along the urinary tract. It could be the bladder, it could be the urethra. And that's what is called hematuria. We mentioned it earlier. I think we mentioned anything hema is blood. Urea is urine. So when you hear hematuria, it means blood inside urine. So you can also see pus in urine. When there's pus in urine, it's an indication that is an infection that's happening within the system that needs to be treated urgently. So what are the things you look at for now? Like I mentioned earlier, the pH, sugar, blood, pus. So you say blood can also appear in stool. So when you see blood in stool, also when it's in urine, is it's called hematuria. When it's in stool, it's called malena, meaning that there's blood inside the stool. And when there's blood inside stool, it's an indication of a lot of things. Number one, it could be ulcer. Number two, it could be cancer of the GI, any of the structures along the GI, the gastrointestinal system. It could be hemorrhoid, what you people call pie. Then these are the possible causes of blood in stool. Then we talk about sputum collection. You know what is sputum? Hello? Hello?
Hello, sir.
Hello?
Hello,
We are
sir.
here, sir.
Do we know what is sputum?
Sputum.
Sputum,
Yes.
sputum.
Yes.
S-P-U-T-U-M.
It is the saliva.
Is it saliva? Sputum is not saliva. Sputum is the when you go to hospital, you tell a doctor that you're coughing. They ask you if you're coughing out anything. I know if you've had cough before and you ask if anything, when you cough, if anything is coming out. Hello?
Yes, that's it.
When
Yes.
you cough, there are some people that will cough it out and spit it out. So that thing you cough out, that is what is called sputum. It's not saliva. Saliva is just spit, just within your mouth. The sputum is the one you cough out. So it's usually collected using a universal bottle. You know, I mentioned this universal bottle earlier for collection of urine, sputum, and feces. That's two specimen. Use this universal bottle. It's bigger than the normal bottle for collection of blood. So what do you look for in sputum? Sputum is tested for blood. When there is blood in sputum, you can use it to diagnose certain diseases such as tuberculosis. That's hemoptysis. That's what they call hemoptysis. That's a presence of blood in sputum. So when you test and see, is an indication that the patient might be having tuberculosis. You can test for microorganisms. This patient might be having respiratory tract infection or pneumonia. So you can also take the sputum and examine them in the lab. Then you can also check for abnormal cells in the sputum. Then sputum test is used to diagnose diseases of the respiratory tract, such as pulmonary TB, pneumonia, and the rest of them, etc. Test tubes, additives, and tests. So we want to quickly go through these types of test tube before we now move to our other topic. The other topic we are going to treat is not large. It's just a straightforward topic. It's not big like this sample collection. Then we are going to start with the color of the stopper. The stopper means the cover, the color of the cover. Then the description of the bottle, then and the use. You will get it in your notes. So when you see a test tube that has a red cover, what it shows that there's no additive required, means there's nothing added inside the bottle. It's usually for used for serum determination in chemistry and blood bank testing. So I think it's self-explanatory. We mentioned it earlier when we were discussing blood bank, that the bottle used is the red cap. So most tests done in the blood bank, they use the red cap bottle. Either you call it the red stopper or the red cap. That usually in the hospital, you hear something like, "Can I get a red cap bottle?" So those ones are used mostly for tests done in the blood bank or serum-related tests in chemistry lab. They have the blue cap. So when you see the blue cap, it means that there is an additive used, and that additive is a sodium citrate. This sodium citrate prevents coagulation by binding the calcium there. It is advised to draw 2 to 3 ml of blood in a tube without additive before transferring it to this tube. So what it's trying to say is that you will draw it from another tube without an additive before you transfer it to this tube. It is commonly used for coagulation tests. Example is the clotting profile. What's a clotting profile? Clotting profile is the test that you do before surgery to know how fast your blood clots or your bleeding time, or what they call prothrombin time. So be sure that if a blade is applied to your skin, the bleeding can stop early enough, so that not after a blade is applied to your skin, the patient is covered. After some time, you hear that this patient has bled to death or has gone into shock as a result of bleeding. So before any surgery is done, this blue cap is used to take a sample, which is taken to the lab to check the clotting time of this patient, to see that, okay, after this surgery, blood can clot in due time and the patient will be fine. They have the lavender bottle. So the lavender bottle is what we usually call the purple bottle or EDTA bottle. So the full meaning of EDTA is ethylene diamine tetraacetic acid. Ethylene diamine tetraacetic acid, that's the EDTA. And this is an additive that binds calcium too for clot formation, commonly used for hematology tests such as full blood counts. So most tests you see in the hematology lab are the complete blood counts, which is called full blood counts, where you see white blood cell count, red blood cell count, hemoglobin, and the rest of them. It is this blood that they use to take the sample for it. They have the green cap bottles now. Here, the additive used is heparin. We discussed, I think I mentioned heparin when we were talking about coagulation. That's agents that suppress coagulation. So heparin is a natural anticoagulant that inhibits thrombin. Thrombin is a sort of clotting factor in blood. It's commonly used for routine chemistry tests, such as electrolytes. That's what you call EU creatinine. So whenever you go to hospital, you see a yellow form whereby they write EUCR. What it means is electrolytes, urea, and creatinine. Electrolytes, urea, and creatinine. That's what it actually means. Hello? Can you all hear me?
Yes.
Okay. So that's what it means. Then tests that you can use this bottle to conduct, like I mentioned earlier, EU creatinine, then full fasting blood sugar. Then you have another type of bottle, which is the gray, though not too commonly used. The additive used in the gray bottle is a sodium fluoride, a preservative that inhibits glycotic action, and potassium oxalate, an anticoagulant that binds calcium. So commonly used for glucose tolerance and lactic acid measurement. So these are for women, all these pregnant women that they come and do this, come for all these glucose tolerance tests. So use this bottle to check their sample. Then you have another one, a red and a gray cap. You have a red with a tint of gray in between. Then this, the additive used here are clot activators and serum gel separator. Serum gel separator. Activator encourages clot formation, where the serum gel creates a barrier between the serum and the cells, which prevents contamination of the serum. It is commonly used for chemistry and immunology testing. So what I'm trying to say in essence here is that it has a red, the cap has a combination of a red and a gray coloring. Then what it does, you can use it, I think we mentioned a serum separator bottle or something like that. This is actually the bottle whereby when you take blood sample in it, the blood stays down while the serum will stay up, so that, say, to avoid contamination of the serum, so that they don't mix up. So this is actually the special bottle for it. Then we are moving to we'll be moving into the lecture for today. But before we proceed, I want to ask if there's anybody that has question as regards this sample collection before we move forward. Any question? Hello?
Hello.
Is there any question regarding this sample collection before we move forward?
So far, there's no question, sir.
Okay. So the topic we're going to be treating today is infection prevention and control. Infection prevention and control. Infection control are those things you practice in the hospital to ensure that you don't move infection from one patient to the other, or from even a patient to yourself. So when you do these things, you're preventing yourself from being infected, and at the same time protecting your patients and even your significant others, maybe your children, your husband, your relative, or whoever you stay with. And that's why it's important that you know all the necessary things you're supposed to do as regards this. Infection is a major threat and a health hazard in all healthcare facilities. Everyone is at risk. Hello?
We are here.
Okay. Everyone is at risk, and prevention of that risk is a relevant part of everyone's job description. So what I'm saying in essence is that as long as you work in a hospital or you work in a healthcare setting, prevention of infection is your job description. It's not like you have a choice. It's your job description. You must stick to the practices, their hospital policies regarding infection control and prevention, which you must stick to these practices to avoid dissemination or contamination or passage of these microbes or pathogens from one person to the other. Hence, infection prevention and control are those practices or limit the spread of infection causing agents, that's microorganisms within the healthcare facility. Then we're going to treat chain of infection. What are the chains of infection? I'm going to mention the one after the other. Then we'll take the explanation. Then when we take the explanation, we'll do an example. And the example is you people that are going to make your contributions regarding this now. In the terms of the first thing that happens in this terms of infection, the first one, the number one thing is the infectious agent. What is infectious agent? Infectious agents are microorganisms, or you call them disease-causing organisms. Hello?
Hello.
Okay. So, like I said earlier, that infectious agents are disease can exist. They can exist either within the human body or outside of the human body. And they are in different forms. They could be viruses, they could be bacteria, they could be fungi, they could be anything at all, as long as they are disease-causing pathogens. So they are classified namely, like I mentioned earlier, bacteria, virus, fungi, and parasites. And it is these agents that cause diseases. And the second one is the reservoir. What is a reservoir? A reservoir of infection is where, like its name implies, where this disease-causing agent lives, their natural habitat. Where do they live? That place that they live is what is called the reservoir. The reservoir could be humans, it could be me and you, it could be harboring bacteria, looking for ways to leave our body to go into another person's body to cause problem. Then you have the portal of exit. What is a portal of exit? The portal of exit is the method by which an infectious agent leaves this reservoir. Example, the hands, the sneezing are considered a portal of exit. Nose, hands, sneeze are considered portal of exit. Portal of exit, how does these organisms now leave your body? When you sneeze, you produce droplets from your nose. So these droplets has left your body through the nose. When you bleed, blood has left your body through your blood vessels of the skin into a surface where it could probably cause an infection. So your skin is a portal of exit that when you bleed. Then when you cough also, you can introduce microbes into the atmosphere, such as for somebody who is having pulmonary TB. When he comes, releases the mycobacterium into the atmosphere, and if anybody inhales it, the person could come down with tuberculosis in no distant time. They have mode of transmission. What is mode of transmission? Mode of transmission is the method by which these microorganisms now are transmitted. For example, you have different methods of transfer of these microorganisms. You have the contact. For example, you have direct contact. What's direct contact? Person to person. Somebody has leprosy, and you're hugging this person. Maybe knowingly or unknowingly, you think it's just an eruption on the skin. You're hugging this person, and fluid from that leprosy touches your skin. Already, in no distant time, you could become a leprotic. You could become a leprosy patient. Not you, anyways. That's for the purpose of this lecture. Then indirect contact occurs when disease-causing pathogens are transmitted through vectors. For example, mosquitoes, flies, dogs that cause rabies, mosquitoes that carry falciparum species and transmit it into you. Those ones are indirect methods of transferring these indirect mode of transmission of transferring diseases into humans, or between one animal or the other. It mustn't be humans anyway. They have droplets. Droplets, like I mentioned earlier, happens when you sneeze. Like during COVID, they were saying that you should wear mask so that not when you sneeze, there'll be droplets on the surfaces, whereby if somebody has a contact with it, maybe it touches the surface and the fluid touches the person's hand, and the person uses it to either touch the mouth or touch food, the person begins to have symptoms of COVID. So those ones falls under droplets. You have airborne, like I mentioned earlier, that somebody who is having tuberculosis, if he coughs, the mycobacterium tuberculosis is being released into the air. So if by peradventure you inhale that air and your immunity is not strong enough to withstand it, you might get tuberculosis in no distant time. You have the common vehicle. What are common vehicles? This refers to transmission of diseases through a contaminated source, such as food, water, blood products, and medical devices. What I'm trying to say here is that if you eat contaminated food, like some people that come down with typhoid fever, some of them is through water and food they eat that they get exposed to these diseases. Through blood products, if a blood product is not screened and by adventure you're transfused with it, you're prone to get whichever organism that exists in that blood product, or maybe hepatitis C blood drops on the surface and that surface is not well cleaned, and by peradventure you have a cut and you're placing your hand on that surface, already you're exposing yourself. That your cut is already a portal of entry for the hepatitis C virus. They have vector-borne diseases, the vector-borne method of transmission. What are vector-borne method of transmission? They are pathogens or agents of infection, or infectious agents carried by insects or animals to which a host is susceptible to. For example, like I mentioned malaria and rabies. Rabies carried by drug, falciparum species. That's a species that cause malaria that exists in mosquitoes. So those are the five modes of transmission. The first one is contact, which I mentioned, direct and indirect contact. Direct contact when you come in contact with the patient, indirect when vectors have contact with you, such as dogs and mosquitoes. They have droplets that is from sneezing. Those are liquid stuff that comes out from your nose when you sneeze. You have the third one, the airborne, which sometimes they are not visible to the eye, but they exist in the air, which if you inhale, that's why tuberculosis patients are isolated, because if they cough, they could spread the bacteria in the air. They have the common vehicles, which I said contaminated food, water, blood products, and medical devices, which if you're exposed to can give you diseases. Then you have a vector-borne, which is animal carrying infectious disease agents. They have the fourth in the chain of this should be 50 because reservoir should have been the fourth. The portal of entry. What are the portal of entry? Portal of entry is an opening in the body of the person who is being exposed to these infectious agents. For example, if somebody coughs now, I inhale the bacteria from what's it called? I inhale the bacteria from somebody who had tuberculosis. I've gotten it through inhalation. So my nose is a portal of entry. So this portal of entry includes the body orifices, such as the nose, the ear, the mucous membrane, or breaks in the skin, which I mentioned earlier when I was discussing hepatitis. They have portals also result from tubes placed in body cavities, such as urinary catheters, punctures produced by invasive procedures, such as intravenous fluid replacement. So what he's trying to say here is that even in the hospitals, when they put patients on catheter, they tell you that once the patient becomes conscious and can urinate, you should remove the catheter because the patient can get infected through that catheter. So infection or bacteria can be introduced into the urethra through the catheter. So that's what he's talking about, tubes inserted into the body cavities or punctures, with the phlebotomy. Then phlebotomy, you use needle to take sample. The intravenous food replacement, you put cannula. So if that's a cannula, if normal process of inserting this cannula, whereby you apply asepsis, that's make sure that everything is sterilized and is clean when you pass a cannula. If an infection introduced there, if you're not careful, by the time you go and check cannulas that have stayed too long, the patient might be having pus from the site whereby you inserted the cannula. So that's why he said tubes inserted into body cavities can serve as a portal of entry. Then body orifice mainly, of course, and the rest of them are the major portal of entry. They have a susceptible host. Who is a susceptible host? A susceptible host is somebody whose immunity cannot stand an invading organism. And some people, they don't have strong immunity, either because they are not eating well or they are stressed. Because most of you do not know that lack of sleep undermines your immunity and can make you susceptible to infection easily. If you're not resting well, if you're not eating well, or if you have an underlying disease that you're not treating very, very well, or you are certain kind of drugs that can undermine your immune system, you're prone to get infection easily. So a susceptible host is somebody whose system now, or whose body cannot resist the microorganisms that is invading the body. So when the microorganism invades the body, they multiply, and this multiplication will result to infection. So the host is susceptible now to the disease because he lacks immunity or physical resistance to overcome invading organism. So I think it's self-explanatory. Why you're susceptible, it could have been host. But susceptible host means the person's immunity is undermined already. Because if some people have a very strong immunity that they can stand certain diseases, which is very, very important. So we're going to take an example whereby you people will make your contributions now. I hope you're all ears now. In the chain of infection, we say the infectious agents, we have the reservoir, the portal of exit, how it leaves the body, mode of transmission, portal of entry, and susceptible hosts. Now, I want to use HIV as an example. Are we ready? Hello?
Yes, sir, we are ready.
You're ready, okay. So can somebody tell me what HIV means? The full meaning. It is like one of the commonest question anybody can ask anybody. So I think we can take this question, then we make our progress from there. Hello?
Hello?
It's the human immunodeficiency virus.
Wonderful. Good. So human immunodeficiency virus is the what? Infectious agent. That's the disease-causing agent. Now, what is the reservoir? What did you say is reservoir? Reservoir is the natural habitat of this organism now. Where do they exist? Where do they live?
They live in the blood.
Blood of?
Human.
Good, wonderful. So humans now is the reservoir of infection. Now, what is the portal of exit?
I think through it can be through It's usually maybe when you have an open wound,
Okay.
at times through
Okay.
sexual activities too.
No. 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 Let me just
Okay.
quickly chip in something. Let me just is portal of exit is the means by which the microbe leaves the body. How does it leave this body now? An open wound. Wonderful. Wonderful. Body fluids. Body fluids. Blood. Serum. Did you hear that? Some will say saliva. They have semen. Vaginal discharge. You know. So portal of exit now could be the open wounds, the urethra for men, then the vagina for women, then the skin, broken skin, which is portal of exit. This falls under portal of the means by which you can leave the body. Then where you were talking about getting into sexual intercourse, those ones falls under mode of transmission. I don't know if you understand it now. Hello?
Okay.
It
Okay,
falls under
sir.
mode of transmission. Those one falls under mode of transmission. What are the mode of transmission? Method by which they are now transferred to a new person. What are these modes? Sexual intercourse, through blood and blood with sharing of sharps, blood transfusion, sharing of sharps, blood transfusion, sexual intercourse. I think these are the major ones. Then if the person has an open wound, another person has an open wound, he can also get it through contact. If blood is on the surface and you have an open wound that touches the place. Hello? I think somebody is
Hello,
really
sir.
okay.
Yes, and so I want a clarification on this last one you spoke about. Because when
Which
she
one?
mentioned sexual intercourse, you said no. And at the same time, you said vagina will bring out fluid, then the male organ too will bring out fluid. Is
Yes,
that not
those are
a
those are
means of
portal of exit.
contacting? Yeah.
No, let me explain. We are talking about portal of
Yes.
exit. Portal of exit.
Okay.
How does it leave the body? Sexual intercourse is mode of transmission. I don't know if you understand it now.
I'm trying to, sir.
Portal of exit is how does it leave the body? How does it leave the body? How does it leave? From where does it leave the body? That's the portal of exit.
Okay.
For which part of the body does this organism leave the body to
Okay.
another person? So how does it leave the body? Is through body fluids, blood, semen, and the rest of them. It's inside them that this organism leaves the body. I don't know if you're getting it now.
Yes, I'm getting it, sir.
Uh-huh. These organisms are contained in blood, serum, semen, vaginal discharges. So
Okay,
it's
okay.
through these places that they leave the body.
Okay, okay.
Good. So sexual intercourse now is a mode.
A mode of transmission.
Mode of transmission now is not portal of exit. It's a mode of
Okay.
transmission because
Oh,
even if they leave the body and they do not encounter anybody, they
yes,
cannot
yes,
transfer it to another person.
yes. I understand now.
And if they even on the surface you apply an antiseptic solution and clean, it can kill it off. If you apply G, it will kill it, and it can be transferred to anybody. Then broken skin, but usually they make it simple through blood and body fluids, and the rest of them. The mode of transmission now: blood transfusion, sharps, sharing of sharps, or improper use of sharps. Then sexual intercourse. Those ones falls under mode of transmission. Then what is the portal of entry? How does he enter the host now? So
So it's through the
when,
same it's through the same body fluid now.
good, good.
It's through blood,
When you
semen, vaginal discharge, and
yeah.
all that.
So when they come together, they are being transmitted. Then who is the susceptible host now? Somebody with low immunity. If this person's immunity is not strong enough, and the person
Yes.
engage in any of these risky behaviors now, this person might get it. So let me quickly chip in this. Mode of transmission for HIV, hepatitis B and C are basically the same. We can also use tuberculosis as an example in this case. What is the infectious agent for tuberculosis? Is Mycobacterium tuberculosis that infectious agent? Which is the reservoir? The reservoir is somebody who is having the disease. Maybe a human being who is having a pulmonary TB. Then what's the portal of exit? The portal of exit is through the mouth when the person coughs.
Mouth.
Yes, when the person coughs. The nose, the mouth, when the person coughs, he releases these airborne microbes that's very, very minute that you cannot see them. Then what's the mode of transmission? It is airborne.
The air.
They are in the air. So it's airborne already. So when you inhale it, you've already gotten the disease. That's mode of transmission. Mode of transmission is airborne. Then what is the portal of
So
entry?
can it be person to person too? Can it be person to person? Maybe someone cough and maybe you're closer to someone that is having it and you take it through your nose, or
Yes.
can it be person to person? No.
Yes.
Okay.
That's why
That's
it's airborne.
direct contact.
It's not direct contact. Direct contact means you're touching. There's a touch. That's contact.
Okay.
Contact means it's a touch.
So
When
I want to
there is
ask a question too.
okay, please do.
Please, can this be applicable to just cough too? Because I've had that experience before. Somebody
Yes.
sat in front of me and he was coughing so badly. By evening, I started coughing.
Yes. This but it's not in all cases because there's something they call community acquired pneumonia.
Okay.
People who live in the same environment.
Yes.
Like when you come to the hospital, you always hear a question like, how many persons? Where do you live?
Yes.
What's the nature of your apartment? Is it a duplex? Is it a 3-bedroom flat? Is it one room? How many persons live in this room?
Yes.
Before you started coughing, was somebody coughing before you? You hear questions like that. You know, this means microbes must have exchanged hands. Either through sneeze or through cough. You pick the microbe. It doesn't necessarily have to be tuberculosis. It could be bacteria or anything. I don't know if you understand it now.
Yes, sir.
So most of the time, upper respiratory tract infections can be transmitted through cough.
How about
Maybe somebody's
sinuses?
coughing.
Catarrh?
Those ones, sinusitis is not easily transferred. Sinusitis is an inflammation. So all those ones, and when you say catarrh, there are different kinds of way in which, or different mechanism by which catarrh can result. One can be allergic reaction. The other one can be flu. I don't know if you understand it now. If
Yes,
it's
sir.
allergy, it's not transferable. If it's allergic, you know, like you hear about, they say people have allergic rhinitis. They are having catarrh, running nose, because they are reacting to something, maybe it's strong smell or cold, anything. Then when you have flu is a completely different thing altogether. That one is infectious, and that's the one that if the person sneezes, you can pick it. I don't know if you understand it now.
Yes.
Yeah. So that is it. So I don't know if we still need to tidy up our tuberculosis on this case so that we can go to the next hearing. So portal of entry now into the new host. We say the mode of transmission. Okay, infectious agent is the mycobacterium tuberculosis. The reservoir is humans. Portal of exit is through the mouth and the nose. Then mode of transmission, um, airborne. Then portal of entry is still the same mouth and nose because that's when you inhale or you open and inhale, because inhalation is usually a product of both the nose and the mouth. You can pick. Then susceptible host is still humans. So that is it for the tuberculosis. I think these were understood now.
Yes, sir.
Okay. So we're going to talk about standard precaution. What are standard precautions? The basic principle in standard precaution is, let me say it now, see every patient as a potential risk. We teach standard precaution, we teach universal precaution. Standard precaution says treat every patient as a potential risk. As the patient is coming to you, what do? Get ready for this patient. So this patient is, in fact, let me put it this way: see every patient as a suspect. Don't go and assume because this man is tall, wearing fine suits and well dressed, with police carrying gun and following him up and down, he will be free from infection. You'll be shocked. You'll be shocked that what you think the man does not have, that he might be the one having it, and he has even given to those people carrying gun and following him. That was an incident we had during the COVID period when I was working in what's it called, in isolation, when they brought the Yobe State Chief Judge that later died. You know, police was carrying bag and following him, not knowing the man had COVID already. And everybody who felt they were closer to him were just following up and down. And at the end of the day, the man died. When they died, all of them started breathing fast and started running back to the hospital. So what standard precaution says is treat every patient as a potential risk, so that you do not infect either yourself, other patients, your co-workers, and your relevant others, maybe if your husband, your wife, your children. So here now, these are infection prevention practices used by healthcare workers to avoid transmission of infectious agents. These precautions are minimum infection prevention practices that apply to all patients, regardless of suspected or confirmed infection status of the patient in any healthcare setting. I don't know if you had that. It's just a brief reading from your notes now of what I explained earlier, that whether the patient is confirmed or is being suspected, you must apply these infection prevention strategies towards the patients. You don't wait to say, okay, let me use my bare hands and be touching this. What comes out now? They say he has monkeypox. You start crying, my God, why did I use my bare hands to touch this man? I should have worn glove. There was glove there. So what is saying, make sure you do the right thing, irrespective of whether patient is a suspected case or a confirmed case. So what are these standard precautions now? They include hand hygiene. Wash your hand before and after every procedure. You don't do because there are 50 patients. After attending to patient 1, you carry the same hand and go to patient 2 to go and attend to the patient because you removed your glove. That is wrong. Because you don't know whether in the course of attending to patient 1, a part of your hand that is not covered by glove touched this patient. And now you're going to the second patient. So it's always advisable that after attending to the first patient, you wash your hand before you move to the second patient. I think I'll make out time and send you a manual on how you're meant to wash your hand. Then you can also use sanitizer to perform high hand hygiene. Is sanitizer. This is commonly done when you have either in the absence of water or you have plenty patients to attend to. You can use sanitizer to perform your hand hygiene, then allow the hand to air dry before you move to the next patient. Then, secondly, the first one is hand hygiene. Second one is personal protective equipment. That's what we call PPE. Whereby you see some health workers coming in from isolation, looking like people coming from the moon. They wear goggle, wear gown, wear earplugs, depending on the type of patients that you're dealing with. They wear gloves, they wear face shields, face masks, and the rest of them. So all those ones, they fall under PPE. So what are PPEs? PPEs are barriers that prevent infection having direct access to healthcare worker in the course of treating a patient. And these barriers must be disposed appropriately, because if you dispose them wrongly, if you dispose them, they call them donning and doffing. If you don't do it appropriately, you might end up dumping them in such a way that if another person has contact with them, the person might become infected. So it's always advisable to wear them appropriately and remove them appropriately. So examples of these PPEs now, personal protective equipment, are goggles. We have goggle. They wear as PPE. This one is to prevent maybe splash. Maybe you're taking a sample or the patient flings the hand, then prevent blood from entering your eyes. Or maybe in the case of droplet, you're taking this sample, this patient sneezes, so that to prevent it from entering your eyes, even if it might be drug administration or anything. Then you have respirators. What are respirators? Respirator is a kind of special kind of face mask. These are N95. They call them respirators. So they are more advanced than the usual face masks you have. They make you breathe better. They have tiny holes in such a way that microorganisms cannot penetrate them easily. Then you have safety boots. They have deep boot looks like what they use in the farm. Deep boots. Those ones fall under PPE to avoid you matching on either a sharp object or matching blood or blood products. They have hand gloves, which is the usual one, you know. Then you have face shields. That face shield, the one that they wear on the face that covers the whole face. That one, you can use it with or without goggle. You can wear it alone. It also protects you from splash or anything, flash, droplets, and the rest of them. Then you have earplugs. This one is in case if there are noise, just to protect your almost all your body orifices. So you can include earplugs to cover the ear. They have the face mask, which is the one you know, which can be used in light cases, just like you're in an emergency now, or maybe in an outpatient department. As patients are coming and going, you wear your mask. So should anybody sneeze, or anybody has something, maybe has a flu, and he's coming in, you can also advise the person to wear their own mask to avoid transmitting to others. So we have the third one, which is respiratory hygiene. The first one is hand hygiene. Second one is personal protective equipment. The third one is respiratory hygiene and cough etiquette. What is respiratory hygiene? Respiratory hygiene is done to ensure that droplets are not sprayed into the atmosphere. You're always advised to cough into your sneeze into your elbow. When you want to sneeze, you put your elbow and sneeze into it. Or you can also cough into your elbow too, to limit the spread of droplets into the air. Very, very, very important. Then in under cough and respiratory hygiene, you also advise to wear mask in the case that you yourself is suspecting yourself of having flu, you can also wear mask to avoid spreading it. Then the fourth one is sharp safety. What are sharp safety? Avoid improper disposal of sharps such as needles, surgical blade, and the rest of them. Usually in the hospital or in most healthcare settings, they provide you a sharp container which is properly labeled, and you have this danger signal on it, a score across with bone to tell you that it's dangerous. You're not supposed to play with it. So ensure that you dispose all sharps appropriately and avoid indiscriminate or careless keeping of sharps anyhow. Then you have injection safety practices or safe injection practices. Ensure that injections are administered using aseptic techniques. What are aseptic techniques? Aseptic techniques are techniques that ensure that whatever you're doing is free from or free of infection. When you want to give patient IV injection, IV cannula, you want to pass an IV cannula, ensure that you use an antiseptic solution to clean the surface before you put your needle or you put your cannula. And when you want to give IM injection, you clean the surface too. So those are aseptic practices, and they fall within the safe injection practices. And after the injection, make sure you dispose appropriately, because if you don't dispose them appropriately, another person could be exposed to infection as a result of it. They have sterile instruments and devices. Ensure that sterilized instruments and devices stay sterilized before use and dispose of them appropriately after use. Each instrument must be sterilized before use on another patient. What I'm trying to say in essence is that you don't, because this instrument is sterilized, you use it on one patient, you want to carry it to go and use on another patient. Once an instrument has been used already, or an equipment or device, you take it back to either the CSSD, if they are the ones in charge of the sterilization, to sterilize again and return for the next patient. Or if it's meant to be disposed, to dispose completely. But in between patients must have sterilized equipment in between them. You don't reuse sterilized equipment, and it's the sterile field must remain sterile. You don't, because okay, let me check if there is a syringe, or let me check if there is a artery forceps. You go and use your bare hand and open dressing pack that you know has been sterilized for dressing. You can open it so that you peep and see if there's a what's it called? If there's an artery forceps or if there's a scissors. You rather carry it to the patient bedside, and when you open and it's now complete, you can close and return it so that they can get a second one for you. Then okay. Then the last but not the least is clean and disinfect environmental surfaces. There's a method of cleaning. You clean when you're cleaning, you wipe downwardly. You don't use either the cotton wool or the gauze used to clean the upper surface to clean the lower side. When you wipe, you come down like that till you clean completely. So the essence of ensuring that the environmental surfaces are clean and disinfected is because there could be droplets. And if you have contact with these droplets now, and maybe you've touched them and you don't know, you use it to scratch your nose, automatically you've inhaled something that is going to cause you disease. So, like we mentioned earlier, that they help prevent transmission of infection from one person to the other. So all hospital surfaces must be clean and disinfected at the same time, using a disinfectant to ensure that they stay clean and sterile, and patients are not exposed to infection. Then I think I need to run it through before we go to the next one. They include the standard precautions now, because you get to most exam questions, they'll ask you what is the difference between universal and standard precaution. So I want to take it here. You have hand hygiene, the first one, personal protective equipment, that's PPE. The second one, respiratory hygiene and cough etiquette. 3, sharp safety. 4, safe injection practices. 5, sterile instruments and devices, meaning that all instruments and devices must be sterilized. 6, then clean and disinfect environmental surfaces. 7. Now, we're going to universal precaution now. What are universal precaution? This refers to the practice of avoiding contacts with patients' bodily fluids by means of wearing non-porous materials, such as medical gloves, goggles, and face shields. Hence, they are steps taken to reduce risk of transmitting infectious diseases through contact with blood or bodily fluids. So what's this one talking about? Universal precaution is more like protecting you from microorganisms that exist in blood or body fluids or bodily fluids. So how do you protect yourself? They say it's by wearing non-porous materials, and these non-porous materials include glove, goggle, and face shields. So in this case now, I want to make a difference now between standard and universal precaution. In this case now, the patient is already suspected. In universal precaution, most cases in universal precaution, the patient is already a suspect. And in universal precaution, is limited mostly to body fluids, unlike in standard precaution. I don't know if you understand it. Hello? Hello? Can you all hear me?
Yes, sir, we're here.
So, in universal precaution, it deals strictly with body fluids. While in standard precaution, it deals with virtually everything, airborne, droplets, and the rest of them. But here, it deals only with body fluids. Then, the last thing we're going to talk about today is the nosocomial infections. What are nosocomial infections? Nosocomial infections are hospital-acquired infections. These are infection that happens in the course of patient stay in the hospital, when a patient is admitted in the hospital. And these infection can be acquired within 48 hours of admission. A patient cannot just come in by 2 p.m. and by 4 p.m. he's already having nosocomial infection. That one is not nosocomial infection. It has to be at least a minimum of 48 hours before you can say it's a nosocomial infection. So this is also known as a hospital-acquired infection. It's an infection that develops while a patient or a person is on admission in a healthcare facility. It can occur within 48 hours after admission to a healthcare facility and can lead to serious health issues, such as sepsis and death. They are actually transmitted to the patient by healthcare workers. Proper hand hygiene and application of other standard precaution practices can help prevent this infection. I think it's self-explanatory. Hospital-acquired infection occurs within a minimum of 48 hours because of patient's admission into the hospital, usually transmitted by healthcare workers. It can lead to serious complications such as death and sepsis, and can be prevented commonly through proper hand hygiene and application of other standard precaution techniques. I think with this, we have come to the end of lectures for today. I don't know if anybody has a question to ask. You can go ahead and ask your question. Hello?
No, sir. I don't have
Okay.
questions. So we're still expecting the book. I don't have any material.
You don't have material yet? Okay, I'll talk to your
Yes.
coordinator. She will send you the ones that are available. Maybe when I send in these ones, you will get them. Oh,
Okay, sir.
any other thing? Any other question? Hello? Hello?
I don't think anybody have questions. So
Okay. Okay.
no, sir. No questions, sir.
You say? Hello?
Questions, sir. I said no question. No questions, sir.
Okay. So in the absence of any question, I think we'll call it a day. I think we can call
Thank
it
you
a
so much, sir.
Yeah, you're welcome. Enjoy the rest of your day.
All right, sir.
Yeah, okay now.
Bye-bye.
Yeah, bye. Take care.
We're having lecture. Let's join the other class.